Hi, I'm Michael Betel, president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with mast cell MASH by advocating for access to approved treatments and care. Today, I have two very special guests. The first is Rachael Sood, who's a diabetes nurse practitioner located in the heart of South Louisiana. She's the owner and chief executive officer of the Diabetes Collective. We also have with us Dr. Jörn Schattenberg, an internationally recognized hepatologist and professor of medicine in Hamburg, Germany. Rachael and I met at the American Diabetes Association conference in Orlando this summer, and I was very impressed by her passion and her experience in the world of diabetes, and specifically CGMs for patients. That's the continuous glucose monitors. She even hooked me up with a CGM to monitor my own glucose levels. Dr. Schattenberg is actually presenting at this week's Paris MASH conference on the use of wearables for steatotic liver disease. His presentation is entitled, "What is the future of wearables in managing mast cell and metabolic health?" So today's discussion is a perfect match. Let's start with Rachael first. Rachael, why have CGMs become so popular as self-monitoring and educational tools for patients?
So continuous glucose monitors, I still am excited about them, and I've been prescribing them for almost 10 years now. There's a large array of them, and it's cool because you can gain knowledge about your health and what's going on inside of your body. You can learn how certain foods and activity and stress, medicines affect your glucose levels, how it makes them go up and down. And it's great because it gives you this immediate feedback. And I think as humans, we just want that. We want to know what's happening and we want results and we want it now. And that's just like the human part of all of us. And CGM does that for us. And it's so popular because it's something we're putting on us. It's not like another pill or a medicine or something that's going in our body. So it's not interacting with, medicines. It's not causing any, problems with our organs. Say if somebody has kidney disease or liver disease or something going on, it's not interacting with anything because it's not going in your body. And I think in a consumer market, and right now we're going towards this just holistic drive globally. We're looking at all kinds of options. How can we better ourselves? How can we get well without just adding tons of pills and medicine? And CGM does that because you see what you're doing right and you see what you're doing wrong, and you can change and do some lifestyle modifications on your own without being bossed around and get that instant feedback. So people love it.
Yes, and I know at the diabetes meeting there was a lot of data that was shared too on how effective it is because you can monitor that. Jorn, like from the liver perspective, is this really new? I mean, obviously the metabolic involvement would mean by definition that a lot of people are going to have type 2 diabetes. So, but is the use of a CGM new on your side?
Well, I think Rachael put it into perspective. She's been prescribing it for 10 years. And I think it's one of the big advances in actually, I consider it a type of biofeedback for our patients living with type 2 diabetes. Of course, there's incremental use and they show up in liver clinics for sure. I have to say, as a gastroenterologist and hepatologist, I'm not too familiar with those devices at this point. And actually, the liver field has not come up with comparable solutions or ability to real life monitor disease activity. And that's a big thing. I guess my one question to Rachael is how do you deal with that anxiety that comes up with patients? Could they be afraid? Are they over focusing on real life values? Because in the physician's office, you sometimes get that a certain concern about numbers, and it's not so much about numbers, it's about how the patient feels, functions, and survives. I understand that the numbers do support this, but I'd say, again, and I'm not a diabetologist, that would be my question as a clinician.
Yeah, I'm happy to answer that. And that's a great question because it comes up all the time and it boils down to CGM use is personalizable, which is the beautiful thing about it. We can adjust alerts and alarms and even silence them and make them personalized for that actual patient. So for example, there's 3 of us on this webinar. my normal glucose level may not be Michael's, normal glucose level. In patients that do not have diabetes, we are looking for a glucose level from 70 to 140. But maybe for a patient that we just start on a CGM that has type 2 diabetes, or we think have type 2, or possibly has fatty liver disease and the beginnings of type 2, we can make the alarms and adjustments. We can just set it on there and customize it for that patient. You can put a glucose level of 100 to 200 or 100 to 250, and even turn the alarms off. There's no need to get frustrated and overwhelmed with alerts and dings. It's just nice to kind of know what's happening, and they can look down at their cell phone or the receiver that goes with it to see what the glucose is. That way it's not so obtrusive. So that's what I typically do. I suggest it to patients that actually are nervous about starting a medicine. I'll say, in clinic, I'm like, look, if you're nervous about starting a pill or a tablet, why don't we just use a CGM? That way we're not putting anything in your body, and we're just collecting information and collecting knowledge before we go making rash decisions. That way we can kind of see what's happening, see what your liver is doing, because as you know, the liver has a large role in, providing this instant glucose supply all day long. So it's nice to see the liver in action. And I don't typically have a problem with it, but again, I've been doing this so long, and I personalize the CGMs. So I make it customized for that person, their numbers.
Rachel,
and Michael, this is coming, JP. I'll hand it back to you. This is where I come in. It's the personalization. I'm on Rachel's side, because the presence or the incidence of liver disease is going to change the insulin sensitivity. It's going to change the glucose monitoring as it's been reported. So, and that's going to be part of my talk in Paris. The first signs of worsening of insulin sensitivity is typically something that has to do with the severity or the presence of liver disease, and that's where we come in and try to, do an active management, either preventive or even just defining the stage of liver disease the patient might be in.
Yeah, thank you for that. I agree with the tailored care approach in all patient related matters now. And I wore the CGM, as you both know, for a month. And so I started to learn, like, for example, there's these things, little oatmeal cookies. They're healthy bites, they're called, Alyssa's, and they're good. They're all, great ingredients and everything. But if I had like 3 of them, it spiked it past the 140, Rachel, right? But so I knew that I could have 2 or 1.5, and then I would just have another one like a couple hours later. So it doesn't mean you can't have those things, but right. So that was part of it, just learning what foods was causing that. But I wanted to ask Rachel too about, is the goal, do you think, other than learning how your body responds to foods, is the goal to try to avoid any spikes? I mean, is that possible that you could go through your day and just like this, or when you eat it?
I am going to respond, and it may not be the popular opinion, but all these little diets and meal plans that people sell, and it's like $1,000 a month, and you get all these little prepackaged bars and shakes, and people will take them, use them. They typically come with instructions, eat every 1 hour, eat this every 2 hours. And, these systems, Nutrisystem and all these bad, things, they're great, but it's the same thing as CGM, except they're all doing is they're selling you the opportunity to see if your glucose stays level, if you only eat a little tiny bit, or maybe a little bit of carbs, whether, a little bit at a time, your body cannot get enough glucose, therefore it cannot rise past a certain level. And if that glucose cannot rise past a certain level, your body cannot secrete a massive amount of insulin because there's nothing there. And therefore your body can't take that sugar and say, hey, we don't need it. We're going to store it. We're going to save it up as fat. So people start losing weight and their glucose is staying stable. It's not the foods that you're buying, it's you're keeping your glucose nice and flat and streaming. So I think you're going to see fluctuations. We all do. And fluctuations are going to happen not just in response to glucose, but as you know, other hormones are at play. You've got adrenaline and dopamine and serotonin, and all the things that make us happy and sad and stressed throughout the day are going to, increase and decrease your glucose levels. So, that's not completely avoidable, but I mean, a flat line of glucose, I've produced quite a few just in the past week with CGM use.
So from Jorn's perspective with his patients, is that, and if they were wearing these devices, is that what he should say to his patients? Do the best you can to keep it as flat as possible, and avoid those extreme spikes? Yes, extreme
I
spikes.
think the patient, so again, going down to personalization, I really focus in on population health, and depending on where he is, people aren't bad, foods aren't bad. It's the amounts of food and the types of activities we're either doing or we're not doing that can, alter things. So I would tell people to just, usually when I put a CGM on someone, I put it on and I say, just, after taking a history and physical, I collect information like, Michael, these are the foods and things that you're eating throughout the day and doing throughout the day. And I'll just pick one thing and say, hey, try not to drink as many Cokes today. And you know what, if you're going to eat fast food, if you're going to sit on the couch and watch Netflix all day, go ahead, do it. Be my guest. And I let people do it for themselves, because I find when you let people drive the bus, you are transferring accountability to them. They're learning about themselves, and we're all going to make decisions on our own rather than like a dictatorship. And, people have to learn on their own. So I don't tell them really anything. I'm like, look, just let this kind of show you what you're doing, not doing, and maybe just cut back to one Coca-Cola a day rather than the 2 that you're doing, and see what happens, and not put a lot of rules,
Jorn, what do you think? Is that going to work, that approach for you with your patients?
Oh yeah, I think that type of biofeedback is great. One thing we haven't discussed, and you discussed the spikes, is actually in the beginning of the development of insulin resistance, you're going to have an overcompensation by the pancreas, secretion of higher insulin. There's some studies I actually found that are done in non-alcoholic fatty liver disease, metabolic dysfunction associated steatotic liver disease, where you can see hypos, so hypoglycemia or dips to the low, in patients with fatty liver disease because they had more insulin secreted. I'm not sure you've seen that, or how do you counsel these patients? That was actually in the context of an oral glucose tolerance testing, which is a different situation than we have with the couch surfers, I would call it. But you see that, Rachael, having them go below the 70?
Absolutely. I see this all day long. I mean, I more see hypoglycemia as a result of high amounts of glucose intake or high carb intake, that rebound effect I'll see. And then I also see hypoglycemia more so as a result of, insulin use, maybe improper, too much, just in my clinical setting. I don't see it as much with liver disease. In talking about the liver, I do tell my patients that, if you're going to have a glass or 2 or 3 of alcohol, even just socially on a weekend, remember that the liver, he's busy. So he is not going to be giving out all that glucose to your bloodstream like he normally would in times of, feast and famine. And that's how we're programmed. So that has been really revealing, especially here in South Louisiana. This is like eating, drinking country. So I have a lot of patients that like to celebrate, and they drink alcohol, and they don't realize that it can cause their glucose to go low because the liver is busy and isn't, sending out that extra storage. So I'm like, hey, eat a little bit, half a piece of toast and protein or something with, or have some nuts, something before you have your glass or 2 of wine. And they really on CGM can see like, oh, wow, I see now. So they don't feel as bad. So that's my experience with lows typically.
Well, you remind me that I want to come see Louisiana again.
It's too fun here. It's too fun here.
Jorn wants to check out the CGM and alcohol combination himself and see how that works out. On my 30-day thing, I don't think I drank anything. That was I should have added that test in there too, Rachael. That was a good idea.
Oh yeah. And I know that, just so you know, I actually saw this at another conference I went to a couple weeks ago, a group of myself and colleagues, we went and had dinner, an early dinner at 5:30, 6 p.m. We all had a really nice steak, big dinner, appetizers, everything. And then everybody went walking around New Orleans, and it was hot, and, we're walking around. So again, we're having lots of activity. Well, one of the girls that I was with, she has type 1 diabetes. And I know we're, talking specifically in our group that, these are patients that you're focusing on that do not have diabetes, or they have type 2 early onset with liver disease. But her in particular, when we got back to the hotel lobby, her glucose was so low and she was feeling fatigued and tired. And I was like, oh my gosh. And I realized we had been drinking wine and we had been walking around. And so there was a lot of activity, and she had had alcohol, and we'd all had a nice big dinner, but all of that activity and the alcohol, she wasn't, able to compensate. So her glucose went low, but we were able to get a Coke in the hotel lobby and treat it, and she was fine thereafter. But without CGM, we
Yeah.
wouldn't have been able to do that for her.
And you know what? Like, having gone through that, I went one day while I was wearing it, and I didn't eat. I think I was trying to watch my carbs or calorie intake that day, and I didn't eat for a few hours. And then I went to play ping pong with my son. I felt
Uh-huh.
sick, like dizzy and
Yeah.
sick. And I looked at my
Yeah.
thing, and it went really low, like in the very low. And so, of course, I had to hit they had the machines, with the chocolate bar. I actually ate chocolate bar, which I hadn't had in years. But you feel that really queasy feeling. I recognize now,
Yeah.
after having worn it, I recognize what that feeling feels like. It's not very good.
No, no, it's not good at all. It feels terrible. We all get hangry and we all have symptoms of hypoglycemia. You just need to eat, you know?
And so, Jorn, what's the next step you think with patients? Because we're trying to avoid what Rachel talked about. As we know, if the liver starts to store the fat that's not being used, right?
Yeah, so clearly the liver phenotype influences the control or the quality of type 2 diabetes control. Again, not talking about type 1 in most of these instances. Undoubtedly, these patients have alterations in liver physiology too, but main focus on type 2 here. I'm hopeful that as we move down time, we're already seeing that in the US, that the addition of a liver-centric or liver-specific drug will further help patients to stay in target range with regards to the glucose monitoring. For the liver field, I think it's still a long stretch to actually monitor liver outputs or disease stages live. It might not be necessary, but the glucose levels as such a central measure of homeostasis that's influenced by liver disease. We'll still have to learn more as a field, I think, about how they react, the CGMs or the glucose levels to certain disease conditions. And again, if we move into the field of patients with cirrhosis, they have severe problems of controlling their glucose homeostasis, and they're even more difficult to control than an obese type 2 diabetes patient that's pre-cirrhotic and has MASLD. So this is really a field where I would also see a benefit of having these patients go on continuous glucose monitoring.
And Dr. Jorn, I wanted to add to you, you probably didn't know this, but my first ever nurse practitioner job, I was working the inpatient unit of liver and kidney panc transplant. So that was my first, I did that for about a year, and I definitely took care of these very, very, very sick liver patients. And as you know, most of them that are inpatient at that point waiting for transplant, regardless of the problems that they had leading up to it, most of them had type 2 diabetes at that point. If not, they were about to, because of all the medicines we had them on in order to get them transplanted. So, I think that we are seeing a time of, early intervention, prevention, instead of just providing sick care and just, oh, somebody's sick. Oh, you have type 2 diabetes already. Okay, now let me stick you on a continuous glucose monitor. So if you put these patients early on in their liver, process, you can put them on CGM. It gives them that biofeedback you were talking about. It allows them to make behavior changes. And, I dare say, because I've seen it in my own clinical practice, but they do lose weight. They change the way they eat. They start losing weight. and they start reversing the metabolic syndrome. And the metabolic syndrome, of course, is this word that we loosely throw around, but part of the metabolic syndrome for me that I see here in my population, certainly a lot of them have liver disease. And we're reversing that and making that better without medication. So there's definitely a big space for research and learning. And I think it's going to help patients in the future just get better overall and decrease their body mass index and get them to goal.
Well, I strongly support that statement. I think the preventive aspect and empowering the patient is very important. Not all healthcare systems spend enough money on those preventive strategies. We're typically coined at treating complications, and it might be different funds, but at the individual level, I think it's important to have, if you decide to have it. Again, I think some patients might not be suitable to have that live biofeedback because they could be concerned or they don't know how to handle it. So it also requires a good amount of education on the patient side.
Rachel, do you have any suggestions where people can learn more about CGM use or what they should do if they are interested after watching this today?
Sure. Actually, this week, the new and only biosensor on the market just came out. It's called Stello, and you can just go buy it without a prescription. So you can go online. It's called stello.com. And there's all kinds of resources there. There's some educational videos, all kinds of information about food, exercise, other metabolic disorders, and how hormones are going to affect your glucose and not. So it's just right there, and it's not like a judgment. You know, you don't have to make an appointment with somebody. You can just go on and access everything. And if somebody wants to buy their own CGM, they can just buy it online, and it gets shipped to their house within a day or two. So it's pretty affordable. It's intended for patients that either have pre-diabetes or don't have diabetes, or type 2 that are not using insulin. So that would definitely apply to the patients, that have fatty liver disease and maybe are just wondering like, well, how is this, affecting my glucose health? So they can go online and buy it. It ships to their house. It's pretty easy to put on, and there's no alarms or alerts. So that's really nice because it's just kind of insightful and it gives them feedback. It's not, like the one that you wore, Michael. So it's not as intense with alerts and alarms. But again, we're talking if a group of patients is just wondering and interested, you can just put it on. I'm actually wearing it. And it was pretty insightful for me because I just went on vacation and I didn't eat the healthiest food when I was there in South Florida. But I saw my glucose spike and I was like, man, maybe I'll make decisions a little differently at the next restaurant I go out to eat.
And I mean, this is what you do every day, right? And so you live life, right? But it's a good reminder when you have the tools. And they have other devices like for health things now, the Aura rings and the Apple Watches and everything. I think as a society, Jörn, I don't know if it's about fear. I know you asked me also if I was afraid. I don't think it's about fear. I think it's just curiosity about self-improvement and just trying to live longer and healthier lives. So thank you both so very much for taking the time today, and we might have to do this again as things progress in this area, because I think it's only going to get busier and we're going to be more informed as well.
Absolutely. I was going to add to your point that we're starting to see research trials coming out on patients in the cardiology space and in the kidney space on utilizing CGM. So I'm anticipating the liver team is going to be shortly to follow.
Definitely discussing this.
Okay, let me know. Keep me posted, Dr. Jörn.
Thank you. Thank you both.